Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.
You're listening to Healthcare Matters, the podcast that pulls back the curtain to help you make sense of complex healthcare economics and policy issues. With us is Dr. Robert Popovian in Washington, D.C. He's a pharmacist, an economist, and the Chief Science Policy Officer at the Global Healthy Living Foundation.
And joining me is my good friend, as always, Ben Blanc, dialing in from the heartland of America, Indianapolis, Indiana. And he is our Associate Director of Digital Production and Engagement. So Ben, we just concluded the Olympics, and there was a lot of discussion among the athletes about free healthcare. I'll bet that that's not shocking to you as a Frenchman.
It's not. The system is definitely different there. First of all, healthcare is largely state-funded, and also the focus on preventive care is really something else. But keep in mind that the French healthcare system is one of the most expensive one in the world. But every system has its perks and its quirks, so maybe we'll focus on the quirks for today's episode. And we all know it, the healthcare system here in the US has its own set of challenges, one of which is patient steering. So let's dive in. And Robert, today we have two guests joining us. With us is Lou Tharp, co-founder and executive director at GHLF. After running a successful international public relations, advertising, and marketing company for nearly 20 years, Lou became a social entrepreneur in 1999 and co-founded Creaky Joints and Global Healthy Living Foundation. Lou is here to share his experience as a fierce advocate and patient. Lou has been on a biologic for the past 2 years and has personal experience with patient steering. And our second guest is Dr. Anne Sydor, who's Director of Research Development at GHLF. And if her name rings a bell, that's probably because Anne has been a frequent guest of the show. At GHLF, Anne helps design and acquire funding for all of our research work. And Anne actually prompted this episode, having recently experienced patient steering related to filing meds for a family member moving away to college. So definitely lots to talk about in this episode. Speaking of, today we'll talk about patient steering, which is a prevalent yet often overlooked issue within the US healthcare system. We'll explore why it happens, how it affects patients, and what can be done to protect patient rights. And before we begin, let's clarify what we mean by patient steering. Patient steering refers to the practice where healthcare providers influence or direct patients towards specific medical services, pharmacies, or providers that they own or have financial agreements with, and often without full transparency. So, Robert, have I captured that accurately?
Somewhat accurate, but today we're going to concentrate on how pharmacy benefit management companies are really steering patients to their privately owned pharmacies instead of allowing patients to go basically to any independent pharmacy or any pharmacy of their choosing. Same concept, though.
So, Robert, can you explain why PBMs engage in patient steering and the implications of their ownership of specialty pharmacies and use of programs like accumulators and maximizers?
So, the reason PBMs steer patients to their own pharmacies is twofold. One is because they own these pharmacies and they happen to make a lot of money off of these pharmacies instead of having them go to an independent pharmacy to get their prescriptions. What the FTC report also found, by the way, that when they reimburse pharmacies, these PBMs actually reimburse better for medicines, their own PBM-owned pharmacies, than actually the independent pharmacies again. So there are multiple reasons why they do this. It's a financial reason. But there's also underlying other reasons because they want to probably administer policies such as accumulators and maximizers, which we've spoken about multiple times on this podcast. And these programs basically take away the patient assistance program that is given by the biopharmaceutical companies, and then they don't apply this patient assistance program towards a patient's out-of-pocket cost, maximum out-of-pocket responsibility, or deductible. And hence, they keep the patients in this perpetual deductible phase. At the same time, the pharmacy benefit management companies, when they don't apply this, they still require the patient to pay for their out-of-pocket cost responsibility, their maximum out-of-pocket cost. And so there are two primary reasons for patient steering. Is one financial, and then for them to be able to administer these type of policies that hurt patients on both ends. One, patient choice. The second one, patients paying more out of pocket than they have to.
Well, thanks for that detailed explanation, Robert. It's clear how these practices impact the broader system. Now, turning to our guests, Lou, as someone who has been directly affected, could you describe your experience with patient steering and how it impacted your care?
Sure. Thanks, Ben. Hi, Robert. So, as Ben mentioned, I'm on a biologic. And as everybody who listens to this podcast know, biologics are not cheap. And the patient copay can be a few $1,000s a month. So I got a copay card and actually a debit card too from the manufacturer. My PBM is CVS Caremark. I have a local pharmacy, which is very close, who I know, who delivers drugs right to the door. So I put through the first prescription with them. CVS Caremark denied it and said I had to go through CVS Caremark. So what happens here is they force you to go to the pharmacy, as Robert says, of their choice. And this happens to be a pharmacy that Aetna owns, or maybe CVS Caremark owns Aetna. It's hard to tell anymore. And I got to thinking about this. Ultimately, I whined enough, complained enough, and testified before the Maryland State Legislature and got it changed. And I'm now with the New York Presbyterian Hospital, which is a specialty pharmacy that I like a lot, and also the same organization that my doctor works for. So here's what happens. The idea that somebody can force you to go to a specific company to get a service that a third party has recommended is just bad business for patients. It's great business for PBMs, for pharmacy benefit managers and insurers. And the analogy here is that several years ago, insurance companies in the automotive sector used to do this all the time. It was very common and still is in some states that if you get into an accident, you get steered to the body shop that either the insurance company owns, the car insurance company owns, or that they have a relationship with that provides them with less expensive bills that they have to cover. So legislatures around the country got tired of this, and they passed a whole series of laws preventing this. Where I live in New York, and conveniently where I testified in Maryland, there are laws that prohibit steering when you have an automobile accident. So the case that I was able to make to the Maryland State Legislature was, you already do this for cars. You've already passed this law. Therefore, how can you not pass one that protects humans and protects our bodies and our access to medicine? The bill was voted out of the House, passed, and I'm checking now to see how it fares with the House of Delegates, the Senate, and we'll know, but we got a very good response. So the point here is that states aren't stupid, and neither are patients. And these kinds of policies come out of health insurance companies all the time. And if you follow the money, they're always geared toward making more profit for the insurance company. And the minute you start to complain, then legislators meet with the insurance companies, and the insurance companies and the PBMs say, well, okay, we're happy to do that, but we're going to raise rates. Now, GHLF has done research in other areas that show that's not the case. That, in the case of prior authorization especially, we have worked with state legislators in the past to pass prior authorization laws, step therapy laws, against a chorus of insurance companies and PBMs saying that they're going to raise rates if this passes. And you know what? They don't raise the rates because that's a whole different hill to climb. That's an obstacle that's very difficult to overcome many times because you have to go through state insurance commissioners and other state bodies. So that main argument works a lot of times, but in practice, it's a false argument.
Well, thanks for sharing your experience, Lou. And what's a bit scary with what you're saying is that, you're obviously well versed in all things healthcare, and you're not afraid to call your pharmacy benefit manager, your insurance provider. You're able to advocate for yourself, and yet it seems like you very often have to push back and to make yourself heard to get what you need. And I understand you've also dealt with patient steering in your family. So could you detail your family's experience with patient steering and how it influenced your approach to healthcare?
Sure. So my youngest child just went off to college and is finishing the pediatric portion of his life and shifting from pediatric care to adult care. as well as moving halfway across the country, much to his mother's dismay. Not really, I'm happy for him, but we were trying to set up all of his health care before he left. We talked to his physicians about the fact that he was making 2 transitions, and we wanted to make sure that his medications that he takes daily wouldn't run out, that on top of all the transitions he was making, he wouldn't have to deal with a shift in how he gets his medicine. So we asked his physicians to give him 90-day prescriptions, which would get him through a 3-month period and allow him time to set up new pharmacies and new physicians where he is now and in the adult healthcare system. I received the regular message from my pharmacy that his prescriptions were ready, and I went to pick them up, and they were 30-day supplies. And he said, wait, these are supposed to be 90-day supplies. I know the doctor prescribed 90-day supplies. Why are we not getting the 90-day supplies? And I was told it had been denied by the insurance company and that I would have to file an appeal. At this point, he's leaving in a couple of weeks, and the whole point is to make sure he has continuity of care with his medications. So I called the pharmacy benefits line, customer service line, and I asked them why we can't have the 90-day prescription. And they say, it wasn't cleared. And I said, okay, well, can you check why it wasn't cleared? But again, I have to ask these questions every time. I'm not getting information unless I ask for it. First, I was told I would have to get the doctor to redo the prescription. And I said, why? He's already done a 90-day prescription. Okay, well, then I guess it has to go through us. And I said to the customer service agent, oh, I understand. You're steering me to your pharmacy, right? And the very nice customer service agent, of course, couldn't say this to me and instead said, well, I don't know why it's happening, but I just know that if you go mail order through us, you'll get the 90-day prescriptions. And here's what the copays are. And these are generic medications. They're not expensive medications. My copays are low. We arranged to have it mail ordered and made that choice as a one-time exception because I won't go through the insurance company's pharmacy for one major reason. And that is the value that I place on having a pharmacy in my neighborhood. My pharmacist is one of my healthcare providers. They've provided us with vaccinations. They've provided us with naloxone. They've provided us with all kinds of care, including life-saving care. And I need a pharmacist in my neighborhood. As a mother of young children, kids get infections. They need antibiotics and they need them urgently. I don't want to wait until they are mailed, nor do I want to have to drive 10 miles across town to pick up antibiotics when I've got a sick kid. I want a pharmacy in my neighborhood. And so when we talk about the financial incentives, Robert, that you brought up, it's not just about increasing their profit margins. It's about the trend in U.S. big business towards monopolies. It's about the verticalization of health insurance and pharmacies, and it's about driving the small independent businesses out of business. I might be able to live without a brick and mortar bookstore in my neighborhood. I wish I had one. I miss it, but I can live without it. I can't live without a pharmacy in my neighborhood. I need my pharmacist and I need the health care that they provide. And this is why, for me, steering is such a big problem and why this time we did it is a one-time exception.
Anne brought up some really good points. And there's one point that I want to take off on that she mentioned. When I was under the kind of the iron fist of CVS Caremark, I would get my prescription biologic delivered by FedEx. Now, I don't know how FedEx is in your neighborhood, but in my neighborhood, the FedEx driver, and this has happened before, slows down and throws the box at the end of the driveway. When they really want to take care of you, they stop the truck and set the box somewhere in the driveway. So one day they left it in the weeds and I couldn't find it. It sat outside in sub-freezing weather for a day and a half. And you're not able to do that with this biologic. So I had to spend an hour on the phone with CVS Caremark before I finally got to a pharmacist who told me how to test the drug and see if it was still good. I've had situations where the FedEx driver just leaves a tag on the mailbox saying, we tried to deliver it, you weren't home, and I was home. I've had it where they say, we need a signature, and you weren't home. And so this caused both delays and what amounted to, in one case, a substandard drug over and over and over again. And the CVS Caremark folks refused to acknowledge this. They refused to understand it. And what it did was give me more ammunition for when I testified before the state legislature in Maryland. And you could see the elected folks, the representatives and the delegates, you could just see them looking, thinking, how could this possibly be? Because they're not sick. They don't understand it. And that happens a lot of times. People think they have good insurance until they get sick. People think they have a nice insurance company. They don't even know what a PBM is until they get sick. And then they have to put up with this. Actually, it's overt abuse because it's planned abuse of the patient. They put up obstacles that they know you're going to have to fight in order just to get your medicine. So what Ann was saying about a pharmacy in your neighborhood, and as I said, my pharmacy knows me. They deliver the drug. They knock on the door and they call before they come over. It's a real person. It's not somebody in a purple uniform throwing a box at me. So good points, Ann.
It's also the delivery systems are problematic. It's also the case that trying to get around these systems is problematic. So in my case, we were looking for generic drugs, and it was pretty easy for the customer service rep to just put the prescriptions through a different system, to enter them into their mail order pharmacy instead of entering it into my local pharmacy and see that it was covered. Again, a clear case of steering. Covered under the CVS-owned mail order pharmacy, but not covered under my local pharmacy. And I didn't have to spend an hour on the phone to speak to a pharmacist. These were simple generic drugs for people with more severe chronic diseases, taking biologics, taking immunotherapies, taking drugs that have a lot more parameters that you have to meet in terms of the right temperature, the right conditions, and getting them on time. The idea that you would have to spend an hour talking to somebody just to find out why you can't get your medication, an hour on hold. I never had to wait an hour at my local pharmacy. I've had to wait, sure. I'm one customer among many, but not hours just to be allowed to speak to somebody. And I think that's another thing that's really problematic about the pharmacy benefit managers and this verticalization of healthcare, which really is moving more towards a monopoly situation.
And you just did it again. You made me think of something while you were talking. So the major issue, the second major issue is you never get to talk to the same person twice at a PBM. They're reading a screen that contains notes from the last person you spoke with, and that person may be a good note taker, they may be a bad note taker. And so you wind up starting from the baseline every time you talk to your PBM. And you go around and around and around with this. And then they put you on hold, and then they transfer you to somebody else. And the idea that you have to listen to push 1 if you're an idiot, push 3 if you're a moron, push 3 if you're impatient. They do that in order to queue you up. And it makes you feel like, well, I didn't have to wait too long once I got through the phone tree. Well, the phone tree is part of the call. And so this designed inefficiency, which allows them to hire fewer customer service reps, and this automation, which allows them to push more work on the reps they have by taking notes, is absolutely unacceptable when you compare it to neighborhood pharmacists who calls you up and knows your name. And when they call your phone, their name pops up. You talk to them. They say, hey, how's your Sharps container? Do you need any alcohol? What's going on? And there's a real connection. You know, would Wednesday be good to deliver this? How about Thursday? And so there's a huge, huge difference here that extends far beyond the simple idea that what seems like convenience really isn't.
Not just what seems like convenience, what they say is cost savings for the entire system. For most of this conversation, I've been, sticking to my role as a parent, as a community member, as somebody who's a care partner to young adults. I've also done policy research with you, Robert, and we've shown that these things they claim are making the system more efficient and saving the system more money are actually simply transferring costs onto patients. And when laws passed at the state level stop those policies from taking place, as Lou said, They scream and cry, oh, your premiums will have to go up if you don't allow us to shift costs onto you that way. We'll have to shift them onto you another way. But we've done the research and we've seen that there's no correlation between increases in insurance rates at the state level and when states do and don't pass laws limiting what insurers can do.
Hearing you both share your stories really brings to light the personal side of this issue. And Anne, you were just referring to the policy research work that you and Robert have been conducting. We actually have a page on GHLF's website where you can find all the relevant information. We built an interactive tool so you can explore healthcare premium cost trends state by state, and you'll find a lot of other related resources on there as well. You can go to ghlf.org/copay-assistance-protection, and the link to that page will be in the episode description for this episode. So, Robert, I'm turning to you because surely there are some actions that can be taken to help patients fight back against patient steering. And my question for you is, what legislative and regulatory measures are being implemented at the state and federal levels to address patient steering and protect patient rights?
So on the state level, several states have passed anti-steering legislation. That means that prohibit PBMs from steering patients to their PBM-owned pharmacies. Texas has done it. I was in Georgia yesterday at the Georgia Bio Association, and Anne and Lou, you would be happy to see that a lot of people are using our research to fight back against the accumulators and maximizers, I was told. So there are states that have passed such legislation. I know Lou also testified in Maryland about this. Now, on a federal level, obviously, there's bipartisan legislation to reform PBMs, and part of that legislation includes anti-steering legislation that prohibits PBMs from steering patients to PBM-owned pharmacies. But also, most recently, there's a Senate legislation by Senator Warren of Massachusetts that has authored it, I believe. And in it, it prohibits PBMs from owning pharmacies. And that's going to be the key here. That will solve a lot of the ills. Because remember, again, going back to the FTC report, one of the major findings of this interim report was that PBMs reimburse differently their pharmacies. They reimburse them much better than the independent pharmacies that there were comparisons. And the whole intent of this is economics, right? It's to drive out business, drive out the independent pharmacies and anybody that is not affiliated with PBMs, because that way they get to have oligopolies and monopolies in the system, and they're able to manipulate it much better. So as we discuss this issue, it's also important to note that Chairman Comer has called on the PBM executives to correct their hearing testimony. The PBM executives recently testified at his committee meeting, and they said that they do not steer patients, nor do they manipulate the reimbursement to favor PBM-owned pharmacies versus independent pharmacies. And the chairman has, in a very unusual request, asked them to come on and correct their hearing testimony because of the FTC report, which has found the exact opposite of those remarks, and he's giving them an opportunity to basically fix what they said at the hearing when they were on the road. So this is a very unusual step by the committee chair. Usually the only time you see this is that in criminal activity, when witnesses are provided an opportunity to correct themselves before they're criminally charged. So it'll be interesting to see what the PBM executives do. And we will be dropping the link to the letter that went out from the Chairman Comer to the PBM executives in the show notes.
Right. Well, thanks, Robert. It's really encouraging to hear about the efforts to address these challenges. And from our discussion today, it's clear that patient steering significantly impacts individual healthcare choices and overall costs. And we've heard from our two guests, Lou and Anne. They've both had to fight back against patient steering. They've had to place those calls to their pharmacy benefit manager, their insurance. They've had to ask the right questions. So it's definitely something we need to make sure that people are aware of and educated about. But I'm not the expert here, so Robert, you have the last word.
So first of all, I want to reflect on something that happened to Anne with regards to this is a generic med, right? This is not an expensive med that she was steered towards a PBM-owned pharmacy. So the question is, is, why does this happen? And I know she lives in Pennsylvania. So in fact, there's legislation in most states, and I think Pennsylvania is one of them, that the PBMs cannot charge the patient more for going through a mail order or their pharmacies than they go to an independent pharmacy. But this is a perfect example that even though we have legislation in the states, PBMs go ahead and ignore it. And in fact, this issue came up yesterday at the Georgia Bio meeting, that it is easier for them to ignore these laws and regulations and just pay a fine or have a squeaky wheel, because nobody's going to pay attention unless somebody like Ann goes to the State Board of Pharmacy or complains to the Consumer Protection Agency within Pennsylvania. So that's a typical example of what PBMs do, is that just ignore everything. They don't care, because at the end of the day, they feel so above the law that even though there's legislation in the states, in Pennsylvania, they require probably that 90 days are to be dispensed by anybody, local pharmacy or mail order at the same out-of-pocket cost. They can go ahead and ignore it, because the consumer, the patient, is way overwhelmed and doesn't have the time and energy to fight them on it. And if they don't complain and they don't file with the corporate agencies, these agencies are overwhelmed and they cannot regulate them appropriately. So having said that, the whole reason for patient steering is not better patient care. Better patient care is not provided by a unknown, like Lou said, somebody that you call on the line and probably don't get the same person. And I'll bet Lou, that person wasn't even a pharmacist. But I guarantee you, when you go to your local pharmacy, you will talk to a pharmacist, not somebody who has answered the phone for the PBM. So it's not for better patient care. Let's put that aside, okay? Let's be honest about it. This is about PBMs wanting to steer patients to their pharmacy for one reason and one reason only: economics. They're going to make more money if you go to their pharmacy instead of going to your local independent pharmacy or local pharmacy of your choosing rather than theirs. And this has detrimental effects, like how Lou has talked about it with regards to quality of the medicine that he's getting, or what Ann talked about it with regards to the ability to access the medicine quickly. This has detrimental effects on patient care. But again, it boils down to economics, and it boils down to PBMs have so much power and they're such large monopolies that the only way we can fix this is for legislative efforts, both on the state and the federal level, to really push back on this patient steering, because it is not for better patient care. It is to enrich the PBM's bottom line, period.
Well, thanks for breaking that down for us, Robert. I think that was some very valuable information for our listeners. Ann and Lou, thanks very much for joining us and for sharing your insights. And that's it for us. Don't forget to subscribe to our podcast on Apple Podcasts, Spotify, or wherever you might be listening so you never miss an episode. And if you have a second, help spread the word by rating our podcast, writing a positive review, and sharing with your family and friends. It will help more people like you find us.
And I want to thank Ann and Lou that came on our podcast. We always like to hear from patients, especially patients who have gone through difficult times accessing healthcare, accessing their medicines, and so on and so forth. But most importantly, if you have questions or thoughts in our audience, please send it to us. You can email us at podcasts@ghlf.org. And if we find something compelling, like we found out about the steering issue from Ann and Lou, we'll bring you on the podcast and we'll interview you, because we want to hear from you, and we will feature you on our upcoming podcasts.
And before you go, make sure you take a listen to some of our other great podcasts on the GHLF Podcast Network. You can find all of GHLF's podcasts at ghlf.org/listen. He's Dr. Robert Popovian.
And he's Ben Blanc. We'll see you all next time.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.